Buenos días a todos. Soy Mario Preti, profesor de Ginecología y Oncología en la Universidad de Torino, Italia. Gracias a Profesor Vargas por la amable invitación. Es un placer comenzar el segundo día de este congreso y lo siento mucho no estar allí con ustedes. Podría preguntar si prefieren mi relación en mal español, en inglés medio o en muy buen italiano. Elegí inglés porque es un poco mejor que mi español. Gracias. Gracias, Victorio. Well, we are going to share the screen. We start our presentation about adenocarcinoma in situ. Cervical adenocarcinoma in situ is a glandular intraepithelial neoplasm. It is a considered precursor of invasive adenocarcinoma of the cervix. The incidence of cervical adenocarcinoma has increased over the past decade, and the mean age at diagnosis 35 years. The incidence rate is approximately 6.5 per 100,000 persons and increasing to 9.3 per 100,000 persons at the peak age of 39 years. Approximately 50% of patients with adenocarcinoma in situ have coexisting squamous lesion, and this is important from a colposcopic point of view too. There are two main groups of adenocarcinoma in situ: the HPV-associated and the not HPV-associated, where we can find in not HPV-associated, in particular, the gastric type. And the localization is more proximal to the endocervix for the HPV-associated, and while the not HPV-associated can extend into the lower uterine segment and endometrium too. And the wide age range of the patient with adenocarcinoma in situ not associated to HPV is not present in the patient which HPV related, because we have a peak at the 4th decade of life. And the frequency, we have most of the adenocarcinoma in situ due to HPV and less than 10% not HPV associated, while 50% of HPV-associated adenocarcinoma in situ has squamous intraepithelial lesion associated. Of course, in these cases, P16 is positive. In both cases, we have the 50% of multicentric disease. This is the invasive counterpart, where the not HPV associated, we have mainly gastric type and clear cell type, but they represent less than 10% of our in situ and invasive adenocarcinoma. We can see that HPV 16 and 18 represent more than 9% of the causes of adenocarcinoma of the cervix. And so the protective effect of the HPV vaccine is in particular represented in 9-valent, where 95% of the HPV type causing adenocarcinoma in situ are contained in the 9-valent vaccine. And we can see that the younger cohort of patients, the already vaccinated patient, have a protective effect for the HPV vaccination, while in the older cohort, not vaccinated, we have not the protective effect of the vaccine. And so the incidence of adenocarcinoma in situ does not change through the years, while is dropped to less than 2 women for 100,000 women in younger patient vaccinated. Importance again of HPV vaccination. More than half of adenocarcinoma in situ are diagnosed with concurrent CIN lesion. How this lesion can be diagnosed? We have three groups of epithelial cell abnormality at the pap smear. The abnormal glandular cell should be categorized in endocervical, endometrial, or glandular, atypical glandular cell, adenocarcinoma in situ, and again, invasive adenocarcinoma with the same subgroup of atypical glandular cell. But a cytological diagnosis of atypical glandular cell carries a subsequent risk of squamous intraepithelial lesion up to 50%, squamous cervical carcinoma up to 1%, adenocarcinoma in situ, invasive adenocarcinoma, but also from extracervical sites, the endometrial, hyperplasia, endometrial, adenocarcinoma, and extrauterine sites to ovarian and fallopian tube. So the importance of the echography in the workup of this patient. And the predictive value of cytology increase when a squamous lesion is simultaneously present with glandular lesion and increase from 66% to more than 80% when not only glandular but also squamous lesions are present in the specimen. And we know that the risk reduction associated with 3-yearly cytology screening is greater for squamous carcinoma and adenosquamous carcinoma than for adenocarcinoma. And so the importance to have some combined screening to have more diagnosis of adenocarcinoma, as only cytological based screening is less effective in preventing adenocarcinoma, and the only benefit we have is the early diagnosis of already invasive carcinoma and the downstaging. So we have more diagnosis at stage 1A and 1B of adenocarcinoma in situ with respect to the past years. And also for the protective effect of the pap smear, we can see that the protective effect at 3 years after a negative pap smear is still present after 3 years for the squamous lesion, while at the 3rd years, the protective effect of pap smear disappears, and so is not so protective for the glandular lesion. So there is a transition from the cytology-based screening to the HPV test-based screening, and the use of liquid-based cytology has significantly reduced the unsatisfactory smear rate, and the cervical brushes have improved the collection and detection of endocervical cells. Also, HPV co-tested the importance of cytology and HPV test and the recognition of HPV negative glandular lesion. And in this important paper is underlined the frequency of the screening result where HPV positive and abnormal glandular cell are simultaneously present. The 5-year risk is very high. And even if this is a not frequent result of the screening, immediate colposcopy is suggested. And the same for the other finding of abnormal glandular cell, with negative or positive HPV test. They are all over the threshold to send patient to immediate colposcopy. And in this meta-analysis of the 4 European randomized controlled study, we have that is demonstrated that HPV test-based screenings provides more protection against adenocarcinoma than cytology-based screening, and even more than squamous lesion, the double protection. So we need to manage the glandular abnormalities. We can have abnormal endometrial cell, and so we need to have endometrial and endocervical sampling, sometimes colposcopy too. And if no endometrial pathology is demonstrated, the need of colposcopy. But one where a typical glandular cell with any HPV result is present, is mandatory to have colposcopy with endocervical sampling, if not pregnant the patient, and endometrial sampling if the patient is older than 35 years of age or less than 35 years with risk factor for endometrial neoplasia, such as abnormal uterine bleeding, obesity, or condition suggesting chronic anovulation. We know that there are no colposcopic imaging pathognomonic for the presence of adenocarcinoma in situ of invasive adenocarcinoma. And this is demonstrated by this study where more than 10,000 patients submitted to lip conization for intraepithelial lesion showed a 6% of invasive cervical cancer. This is the sensitivity of cytology, 65%, and 91% of HPV tests for adenocarcinoma. But it's important that the ratio of cervical cancer confirmed by lip in adenocarcinoma in situ was significantly higher than high-grade C. So we found invasive cancer in 1/4 adenocarcinoma in situ, because not all the glandular epithelial can be inspected in colposcopy. So punch biopsy can skip early lesion, probably in the crypt. And in this other study, it's shown that 70% of the patient had unsatisfactory colposcopy. So the classification of colposcopy underlined, in particular, the last American Society of Colposcopy classification, when is fully or not fully visible the squamous columnar junction. This is important to underline the binary combination, fully or not fully visible. But most of the abnormal colposcopic findings are related to the squamous lesion. Of course, there are a grade 2 major finding, abnormal finding, the catheter crypt opening, or even worse, the fragile vessel, the irregular surface, the esophageal lesion for invasive lesion. But the literature is going to search new colposcopic picture to increase the sensitivity of colposcopy for the detection of glandular neoplasia. In particular, the obstructed dilated grouped cell, the fused acetoide villi with invaginated border, and the atypical vessel in cylindrical epithelial area. And this is another Brazilian study where other aspect, colposcopic aspect of the adenocarcinoma in situ is researched to improve the sensitivity of colposcopy. And in this Italian study is underlined that squamous lesion could be considered a lucky marker for the presence of the hidden glandular lesion, because about 8% of these patients were diagnosed with occult glandular lesion, so a failure in about 10% of the cases of the colposcopy. The key point of colposcopy is that glandular lesion alters the cervical surface very little, and often the neoplastic glands are buried beneath the surface. Most glandular lesions lie within or close the transformation zone, and half of them are associated with squamous component. And punctation on mosaical vessel pattern, so typical for squamous lesions, do not appear in glandular disease. So how we manage now, after diagnosis, adenocarcinoma in situ? If the initial cytology is favored to neoplasia, even if we have no adenocarcinoma in situ or cancer by colposcopy and biopsy, we need to have, is recommended, diagnostic excisional procedure. But if initial cytology is abnormal glandular cell or an endometrial cell not otherwise specified, without suspicious of neoplasia, and the colposcopy doesn't find CAN2 plus adenocarcinoma in situ or cancer, is recommended by the American Society co-test at 1 and then, if negative, at 2 years. And when both negative, co-test 3 years later. Of course, when glandular neoplasia of CN2 plus are found, the manage according to the guideline for pre-invasive lesion are recommended. This is different from what we recommend in Italy. Our flag is quite similar, because if the colposcopy and the endocervical curettage and the biopsy don't show, are negative or show low-grade squamous intraepithelial lesion, we repeat colposcopy, pap smear, endocervical curettage within 3 months. So it's important to be sure that no glandular lesions are present. Of course, when histological diagnosis is high-grade CIL and or adenocarcinoma in situ associated, excisional treatment is recommended. When endometrial or invasive adenocarcinoma are found, they must be managed according to the oncological guideline. And when we have, the histological diagnosis of adenocarcinoma in situ of the biopsy, we can have excisional treatment with endocervical curettage. And when the definitive diagnosis is adenocarcinoma in situ associated or not associated to high-grade CIL, if the patient is not planning a pregnancy, is recommended simple hysterectomy if negative margin on conization, or modified hysterectomy if positive margin are present of conization. But if patient is planning a pregnancy and she has positive margining, we need further conization to reach negative margin. With negative margin, we can follow the patient. So follow up in patient, in a woman desiring childbearing with negative margin on cervical conization and negative endocervical curettage should be co-test and the cervical curettage every 6 months for 3 years, then yearly until hysterectomy. So if co-test and the cervical curettage are negative for 5 years, it is acceptable surveillance every 3 years. It is important that all the procedure should be done under colposcopic guidance. It is important that the cone length should be at least 10 millimeters in women desiring childbearing and at least 18-25 millimeter in other patient. Is not acceptable top head excision, but single surgical specimen must be obtained. And the histological examination should confirm the diagnosis, rule out stromal invasion, and evaluate concomitant squamous lesion. And the cervical curettage should be done after the conization to facilitate the subsequent conservative management, because we know that if the margins are negative, less than 3% of the patient recur, and the risk of subsequent invasive cancer is low, and the contrary of positive margin. And how should adenocarcinoma in situ be managed during pregnancy? In absence of clinical or histological suspicious of invasive cancer, excisional procedures are not recommended during pregnancy. And if the procedure, excisional procedure is performed during the pregnancy, owing to the suspicion of invasive cancer, placement of prophylactic cerclage, cervical cerclage is acceptable. The key messages are that all women with cytological diagnosis of abnormal glandular cell or adeno in situ carcinoma, adenocarcinoma in situ, should undergo to colposcopy, endocervical curettage, and possible endometrial sampling. Cervical conization should be in a single surgical specimen, and negative margin should be achieved. In case of positive margin, a further conization should be done, if possible, in child-desiring patient. And women should be offered hysterectomy if childbearing is completed. Women desiring childbearing with negative margin and negative endocervical curettage should enter in a strict follow-up. And again, thank you so much for your kind invitation.